start out by welcoming everyone to the third meeting of the joint Legislative Oversight Committee on Health and Human Services, Subcommittee on Medicaid Reform and DHHS Reorganization. And we wanted to make sure, after I think we had a very productive and informative meeting earlier this month, hearing from experts, three experts from around the country on their individual Medicaid programs and how those work, and it's very, very educational. We wanted to make sure that we had an opportunity today to hear directly from North Carolinians and from advocacy groups that had an interest in what this subcommittee has been tasked to work on. So we will start with that briefly, but I want to first introduce the Sergeant at Arms from the House. We have with us Reggie Sills, Marvin Lee, Young Bay, and Ed Kessler from the Senate Sergeant of Arms, along with Giles Jeffries. And at this time, we've had a public sign-up sheet in the back, and there's still one back there for anyone else interested in signing up. But we will start with the list that we have right now, and Young Bay will he is keeping time, so as you go through your 3 minutes, you will see he will hold up, I believe, a card that has a minute left and then a stop card as well when your time is up. So at this time, as you're asked to come forward, if you'll go to that mic back there where he is at, you'll be able to start your 3 minutes, and we're going to start with Dr. John Morrow from the North Carolina Association of Local Health Directors.
Good morning, Representative Burr.
Good morning, Dr. Morrow. I ask you, and for the rest of the presenters that come up as well, if you have comments that are, you have written comments that you could submit to our clerk as well, we would welcome those being submitted after you use your 3 minutes.
Thank you, sir, and I've already submitted mine. Senator Heiss, public legislators, thank you for having me this morning. I won't take too much of your time. You're going to hear from a lot of different folks this morning, and I'm really here representing, I'm a county health director, I'm a family practice physician, I'm director of public health in Pitt County, and past president of the North Carolina Association of Local Health Directors. But you're going to hear from a lot of different perspectives today, and I'm here today to make sure that you don't forget local health departments. Local health departments, we have the first local health departments in this state, or in this country, and we've been around for over 100 years now. We have a local health department in every county in this state, and in some places we're the only rural providers in these small counties. We're seeing over 100,000 non-duplicated individuals per month, and about half of those people are on Medicaid. Unlike many of the other providers, we are focused on population health, and we're focused on prevention. We work closely with the State Division of Public Health, with community care networks, and other community hospitals and providers to improve the health status of all the people in our communities. Medicaid is more than just an insurance provider, and I think we've got a lot of folks today who are worried about the insurance part of Medicaid. But Medicaid needs to be seen as a tool which we use to improve the public's health and to improve our economy. Until we use Medicaid to help build healthier communities and not just treat disease, but prevent it, we will not attract good business and jobs to North Carolina. Local health departments are critical to creating this new Medicaid system and to creating a system of not just health care, but a system that creates health. Medicaid is also a significant revenue provider for local health departments who have recently experienced budget cuts from the federal, state, and local levels. We're struggling today to maintain staff. We're struggling today to provide services that no one else provides. Hospitals, other clinical providers are also struggling with Medicaid revenues. I understand that. One of the jobs that we're working with today is preparedness for things like Ebola. We use those Medicaid revenues to help staff, and those nurses who provide those clinical services are the same ones who help us get prepared for things like Ebola. Thank you, sir.
Thank you, Dr. Mark. John Nash from the ARC of North Carolina.
Chairman Burr, Chairman Heiss, members of the committee, thank you for inviting us to speak today. The ARC of North Carolina is both an advocacy organization and a provider organization, and my comments today reflect the input of our staff, our board of directors, our membership, and over 60 years of experience in serving the intellectual and developmental disabilities community. The ARC believes our current Medicaid system for people with intellectual and developmental disabilities, or IDD, is not effective. Any new system designs must be highly efficient and cost-effective, but most of all, accountable to the individuals receiving those services. The system of delivery of services for the IDD population has been in continual change for several years and is extremely fragile. We urge caution on any additional changes, and we respectfully request that any future plan for North Carolina includes meaningful stakeholder input, is rolled out carefully with time for fine-tuning, and must respect the needs of the individual. To this end, there must be an allowance for self-direction. To be effective, the system must be based on outcomes which focus on life goals and reflect the whole person. Short-term cost efficiencies often lead to greater long-term expenses and cannot be achieved on the backs of individuals with disabilities living in the community. And any new system must be created to address the growing wait list for the IDD population. No family should have to wait 7 years to receive their needed services. In addition, we must increase funding and support the NC START system because our crisis system for people with IDD is overburdened and underfunded. We believe that the current provider system is unduly burdened by repetitive reporting and audits. The provider payment system needs to be cleared of needless red tape, and subjective criteria to measure the progress for people with IDD needs to be avoided. There must be accountability measures with an appeals process that is independent of the implementing agency. The system of integrated care cannot be based on a medical or a curative model. And there must be choice of network and providers in the plan for both behavioral health services and for physical health services. Any new system must include independent case management. The damage from the elimination of independent case management and the lack of a comparable service for providers, families, and individuals with IDD must be addressed. In conclusion, the ARC of North Carolina is ready to assist with the work and with the legislature to address the real needs of our state. We understand the need for fiscal responsibility, for sustainability, and in creating a system that addresses the needs of the individual in a comprehensive manner. Any system design must take into account that individuals with IDD are valued members of their families and communities, and that they deserve innovative quality services and supports. We look forward to participating in this collaborative process with any who would ask us and invite us. Thank you very much.
Thank you, Mr. Nash. Ken Jones from East Point MCO.
Good morning. My name is Ken Jones, and I'm the director of East Point. East Point LME MCO is one of the 9 Medicaid behavioral health IDD managed care organizations charged with implementation, refinement, and management of North Carolina's Medicaid 1915 BC waiver. East Point serves the 3rd largest Medicaid population with a total of 183,000 covered lives in a 12-county service area. We have a budget over $300 million. Our service population includes the most fragile of our citizens, those dealing with a severe mental illness, substance abuse issue, and an intellectual and developmental disability issue. East Point, along with North Carolina's other public LME MCOs, emerged from a multi-year change process that required a large-scale consolidation of old area programs, a dramatic change in the role of a provider, to a system manager and an absolute commitment to changing the culture of our organizations. It must be noted that LME MCOs, as managed care entities, are now delivering significant benefits to our state and the citizens that we serve. We offer access to quality care, competent oversight, and effective provider choice, all for predictable cost in the Medicaid program. We have managed to bring quality and cost containment to a significant segment of the Medicaid budget. We have initiated and will continue to move forward with efforts to promote integrated care programs that address the comprehensive needs of our consumers. Our recommendations include give LME MCOs the opportunity to build on the current successes in cost containment and the management of a high-quality care delivery system. LME MCOs should be encouraged to be partners in the creation of integrated healthcare systems that yield better outcomes for our recipients by partnering with local hospitals, providers, and even FQHCs. Build on existing structures and achievements in Medicaid health management. A good example is the work that CCNCs and MCOs did together in creating primary care medical homes for behavioral health and IDD consumers. We also recommend seeking out mirroring success of national models such as Pioneer Medicare ACOs, which have generated success in terms of cost savings, increased quality outcomes for members. Also, keep in mind managed care models, both provider and MCO-led, are plentiful and demonstrate the value that these partnerships can bring to our healthcare system. For long-term financial stability of our system and the quality care of our consumers, East Point encourages building on the demonstrated success of the LME MCOs. Thank you.
Thank you, Mr. Jones. Next we have, and apologize if I'm mispronouncing your name, trying to get the handwriting, Dr. Catherine Perena from the North Carolina Nurses Association.
Good morning, Chairman Heiss, Chairman Burr, and honorable members of the General Assembly. My name is Catherine Pereira, and I practice in Durham as a family nurse practitioner. I also serve as coordinator for the Family Nurse Practitioner Program at Duke University. I have been a practicing nurse for over 33 years, and I have been a resident of North Carolina since 2000. And I am speaking on behalf of the North Carolina Nurses Association today, the professional membership that represents over 125,000 registered nurses in our state, and I thank you for the opportunity to speak. As nurses, we fully understand the complexity and importance of this issue. We are equipped to be full partners in the reform of our state's Medicaid system, both from a structural standpoint and as from a healthcare delivery standpoint. Regardless of the reforms pursued by this body, we nurses should be at the table as active participants in the discussion. We have a wealth of firsthand knowledge about how the challenges and limitations of the Medicaid system impact patients and their health on a daily basis. As is often the case in our practice settings, our best solutions emerge when we have a representative mix of providers working together as a team. Regardless of the future structure developed for DMA and Medicaid, NCGA is confident that our state can increase access to safe, affordable, quality health care through efficient and effective utilization of our healthcare workforce. Advanced practice nurses, which include nurse practitioners, certified registered nurse anesthetists, certified nurse midwives, and clinical nurse specialists, are already playing a critical role for Medicaid recipients. We know the current availability of Medicaid providers is limited in this state, and advanced practice nurses are an important and extremely qualified provider resource for care delivery, especially in the areas of the state that lack access to primary care, prenatal care, and psychiatric care. Nurse practitioners have been a mainstay for providing Medicare services in underserved communities, and harnessing NPs helps address a common barrier to care for Medicaid beneficiaries, the shortfall of primary care providers. NPs have special preparation to provide care for the indigent, and we emphasize care of patients who are limited resources, financial and otherwise, in our education. As a nurse practitioner who currently cares for some of the 674,000 patients in North Carolina with diabetes I see every day, what happens to patients who do not get adequate care for their diabetes and thus experience the harsh and costly complications of this disease, such as kidney failure, vision loss, amputations, and heart disease. As an example, the average hospital cost for a patient who gets a diabetes-related amputation is $81,000. We must invest on the front end with excellent primary care services that include nurse practitioners as part of the healthcare team. And thank you for listening to me today.
Thank you. Mr. John McMillan, representing Pharma. And also for those listening and those in attendance, all the comments that you're hearing and those that have been submitted to the committee will be posted on the committee's website.
Thank you, Mr. Chairman. My name is John McMillan, and I represent the Pharmaceutical Research and Manufacturers of America, also known as Pharma. As North Carolina reforms its Medicaid program, Pharma supports the inclusion of important patient protections. Patients and their healthcare providers must be able to gain access to the services and innovative treatments that best meet their individual needs and encourage continued medical progress, while at the same time improving healthcare coordination, efficiency, and quality. North Carolina is considering a Medicaid managed care model and an accountable care organization model as options for reform. Emerging payment and delivery reforms hold promise in advancing the efficient delivery of high-quality, personalized care. ACOs and MCOs have potential to generate health system savings while improving or maintaining the quality of care provided to patients. We have prepared a statement outlining these best practices and patient protections. I practiced all weekend trying to talk fast enough to present all of those within the allotted time, but was unsuccessful. So I'll simply hand up the statement for your consideration. Thank you.
Thank you. Lisa Wainwright from East Carolina Behavioral Health.
Good morning. Thank you, Chairman Burr and Chairman Heiss. I'm Lisa Wainwright from East Carolina Behavioral Health. We are a local management entity managed care organization based in Greenville that serves 19 counties in eastern North Carolina. I really appreciate the opportunity to be here to talk to you about the role that LME MCOs can play in addressing the goals of this General Assembly for Medicaid reform. You've clearly outlined your goals in Senate Bill 402 as to achieve a predictable and sustainable Medicaid program, to increase administrative ease and efficiency for providers, and to provide for whole person care. I'm pleased to report that the LME MCOs have successfully achieved those same goals. With all counties in the state covered under the state's 1915 BC Medicaid waiver, the behavioral health and intellectual and other developmental disability services component of the Medicaid budget is fully capitated. That portion of the budget is completely predictable and sustainable. The state realized savings in the initial move to managed care of in excess of $150 million. Since then, capitation rates have declined as services have been effectively managed. At ECBH alone, rates have decreased by $14.31 per member per month, resulting in an overall savings to the Medicaid budget of $25.4 million or $8.6 million in state appropriations. This has occurred at the same time that we've been able to raise rates for certain critical services and increase access to evidence-based practices, those services that have been proven to work best for people. We are not serving fewer people. We're serving basically the same number of people as receive services in the unmanaged system, but the difference is that we now have the ability to manage services to ensure that Medicaid beneficiaries receive the most appropriate service in the right dosage and for the proper duration at the right time. LME MCOs are also increasing administrative ease to allow providers to be more effective. We have the ability to pay providers in a more efficient and effective way. And we're doing things like case rates and experimenting with different payment methodologies that mean providers can focus on care rather than chasing the 15-minute billable unit. We're also focused on integrated care. It's the right thing to do. We work with our healthcare partners to ensure that people live full and complete lives in the community. It is the right thing, and frankly, it benefits our bottom line. One of the things that is a little different about the specialty service system, however, is that when we talk about whole person care, we also talk about those other services such as employment and housing. The National Alliance on Mental Illness has recognized that housing, lack of safe and stable housing, can be a huge obstacle to people recovering from mental illness, and employment can be a big benefit. One of the other things I wanted to point out very quickly in my remaining 30 seconds, 25, is that the regional geographical boundaries of the LME-MCO actually give the state more accountability, because you know who is exactly is responsible for ensuring services in any given community. Thank you very much.
Thank you, Ms. Wainwright. Rob Thompson from NC Child.
Thank you, Mr. Chairman and members of the committee, for the opportunity to speak today. My name is Rob Thompson, and I'm the Director of Communications with NC Child. NC Child is a statewide nonprofit organization that advances public policies to improve the lives of North Carolina's children. We recognize the need to reform our state's Medicaid system to improve outcomes for children and to control growing costs. As you proceed with your deliberations, we hope that you will take into account the unique challenges that are presented by serving children, who constitute well over half of the entire Medicaid population. We believe that a provider-led or managed care framework has the potential to improve outcomes for children and to enhance efficiency within the Medicaid system, if it includes specific safeguards and assurances that children, particularly those with special needs, will not lose access to needed services. First, it is important to carefully consider the quality metrics and outcomes used to measure success in pediatric care in either a provider-led or managed care-based system. The potential for immediate cost savings within the pediatric population is limited. The majority of savings from pediatric care occur later in life as a result of avoided and better managed chronic conditions, such as diabetes, obesity, and heart disease, or in other parts of the budget, including juvenile justice, education, and even other divisions of HHS. Success by pediatric providers should be measured using public health and preventive care indicators, not just immediate cost savings. This will pay handsomely in avoided costs in future budget years. Second, we need to make sure that children with developmental delays and disabilities receive the treatment they need. When addressed early, some developmental delays can be resolved or moderated, resulting in better outcomes for children, better outcomes for the child and substantial cost savings. However, many children with developmental delays or disabilities will not get better and will need continuous high-level care throughout their childhood and adult lives. While Medicaid should incentivize early diagnosis and treatment, it should also provide adequate and ongoing habilitative services for children in need. Third, the integration of behavioral health and physical health should be pursued, but deliberately and with caution. Integration is an exciting idea that holds the promise of better outcomes for our state's Medicaid population. It is, however, a strategy where no blueprint for success exists from our state or from other states. As such, we should move slowly and carefully to ensure that any attempts at integration do not have unintended consequences, particularly with our newly created system of LME MCOs. As a starting point, we should consider initiating coordinated care with an interdisciplinary team for patients and medical and mental health systems, while identifying and expanding pilots for integration. In summary, we hope you will take into account the unique challenges that are presented by serving children, and particularly children with special needs, as you craft your proposals to reform our Medicaid system. Thank you for the opportunity to speak.
Thank you, Ms. Thompson. Nicole Coram with the National Alliance of Mental Illness, NC.
Good morning. My name is Nicole Karam, and I represent the National Alliance on Mental Illness North Carolina, also known as NAMI, a part of the largest national grassroots organization that promotes recovery and wellness for those living with mental illness. We speak on behalf of the thousands of North Carolinians living with mental illness in our state. We would like to thank you for inviting public comment, along with the time and effort you all are giving to such an important issue. At NAMI, we believe that everyone deserves to live a productive and healthy life. Those living with mental illness want the same things as others: a safe place to live, stable employment, and meaningful relationships. And they want to have a voice in the changes that are made that will deeply affect their everyday lives. When people do not have access to appropriate treatment, costs go up through expensive emergency department visits, incarceration, and lost wages. However, with the right care at the right time, many live healthy and productive lives. We applaud the thoughtful approach that has been undertaken by the committee in order to ensure our public system is working for those who need it most. Simply put, the mental health system should be simple, straightforward, and have a robust array of services that are easy to access. We support integrating physical and behavioral care, as research indicates many who live with mental illness have chronic medical conditions such as heart disease or diabetes. Additionally, we support initiatives that build on North Carolina's strengths, such as the LME MCO system and nationally recognized programs like CCNC. We support initiatives that are fiscally smart, outcome-driven, predictable, and most importantly, provide excellent and timely care. While considering Medicaid reform, we ask committee members to consider how reform will impact those living with mental illness in our state. To make further organizational changes will result in more confusion and disruption for those who have already experienced constant changes through the continuous mergers of the public MCOs. We oppose any measures that would further complicate the system, such as moving DMA out of DHHS and changing the governance structure for oversight of the Medicaid program. These changes will add yet another layer of red tape on an already complicated system. Let's give the current system a chance to mature. And let's consider, now that the budget is under control, Medicaid expansion to make sure that healthcare is a possibility for another 300,000 to 500,000 North Carolinians. Thank you.
Thank you. Elizabeth Huggins with the North Carolina Pediatric Society and North Carolina Academy of Family Physicians.
Good morning, Chairman Burr and members of the Joint Legislative Oversight Committee. On behalf of the nearly 6,000 combined members of the North Carolina Pediatric Society and the North Carolina Academy of Family Physicians, I'm Elizabeth Hudgens, Executive Director of the North Carolina Pediatric Society. Our two organizations represent the bulk of primary care physicians in North Carolina and the physician backbone of the state's Medicaid system. Dr. Robert Barther is here also today, a past president of the North Carolina Academy of Family Physicians. Thank you for evaluating our Medicaid program to determine what is best for our children and families. As the reform goes forward, we believe it's essential to make a correct diagnosis of the North Carolina Medicaid system and not just treat the symptoms. Our doctors can tell you firsthand that while there are aspects of our system that may be improved, there are many care delivery functions within Medicaid that are healthy and working well. Reform can build on what is working and leverage the investments we have already made. We have 5 main points. 1. Reform should build on the success of medical homes and provider-led initiatives. A first step in reform is sustaining the proven medical home networks of community care of North Carolina that we have worked so hard to build. Additionally, reform must ensure competition at the provider level by taking into account the role of independent practices and ensuring their viability into the future. 2. Evaluation metrics should reflect the importance of prevention and the gains we have made. Through medical homes, pediatricians and family physicians have already produced significant savings from the healthcare system while improving care. Community Care of North Carolina has documented these savings. 3. Keep DMA part of DHHS. We appreciate the steps being taken within the department to improve the organization of the Medicaid program and its financial controls. We believe that Medicaid should remain within the department because of the key connections to the Division of Public Health, Mental Health, Social Services, and other state facilities to coordinate whole person care. That is best accomplished by continuing to improve the internal operations of the department. 4. Reform should make the system easier for patients, families, and doctors to use, not increase barriers like paperwork. We need our state family physicians and pediatricians concentrating on providing care for patients, not straining to jump administrative hurdles. Not only is this important for doctors, it's important for families to have as many providers as possible able to participate. 5. Reform should be North Carolina focused and North Carolina based. Let's retain and invest our healthcare dollars in North Carolina, giving care that patients need, not paying for administrative overhead funneled to out-of-state companies. As frontline providers of primary care, our state family physicians and pediatricians want to assist and work with the General Assembly and administration. You can enact reform that builds on medical home, fixes things that are broken, and brings constructive changes for family, health care providers, legislators, administrators, and taxpayers. Thank you.
Thank you. Ed Turlington from Brooks Pierce on behalf of United Health.
Morning, Mr. Chairman, members of the committee, Dr. Voss, Dr. Cummings, good to be here with you today. My colleague Chris McClure and I represent United Healthcare, which many of you may know is a leader in North Carolina's business and healthcare community, serving over 1 million North Carolinians with 4,000 employees in North Carolina, including 2,000 in Greensboro at its customer center. It's also a partner to state employee retirees for a Medicare Advantage offering. On behalf of North Carolina CEO Garland Scott today, I'd like to offer comments that I'll hand in, making 3 basic points. First of all, focusing on money, and all of you know about this from your work here. The trend line in North Carolina has been up on Medicaid spending in recent history. You know the stats. Between 2003 and 2012, spending increased 90%, and state share of Medicaid between FY11 and 14 went up 38%. Because of that spending, perhaps you and other leaders could have invested in education, environmental protection, public safety, and economic development with some of that money. The second point Mr. Scott's letter makes is to suggest 3 guiding principles as you consider this important issue. First, provide high-quality health care and delivery for Medicaid recipients. Second, seek budget predictability for the state and its taxpayers. And third, foster marketplace competition that drives a more efficient and effective health care system for Medicaid recipients. Now, you all heard a couple of weeks ago on October 6th, presenters from 3 other states, Florida, Ohio, and Virginia. And what I was struck by in those presentations is the creativity and state-specific approach those leaders have made. We think you can do the same here. You probably know that 37 states have some form of Medicaid managed care, and as you consider this important issue, United would ask you to consider those creative approaches and many other states. Mr. Chairman, members of the committee, Mr. Scott, United looks forward to working with you to modernize Medicaid in North Carolina.
Thank you. Cody Ham, North Carolina Hospital Association.
Good morning, Mr. Chairman, Senator Heiss, Secretary Voss, members of the committee. My name is Cody Ham from the North Carolina Hospital Association. North Carolina hospitals believe that the reform of Medicaid program is essential for its viability, for the solvency of our state budget, and the patients that we serve each day. Your hospitals fully support the goal of the Senate, the House of Representatives, the Governor, and the Secretary to establish a sound Medicaid program. And since beginning down this path, your hospitals have partnered with our doctors and our other provider groups to develop a solution to Medicaid that will deliver your budget certainty while providing high-quality care. Building on a successful medical home model established by Community Care of North Carolina, we promise to provide comprehensive care to the Medicaid population at a set cost to the taxpayers through the use of accountable care organizations. We understand that the current healthcare model is unsustainable. We have been working with the private sector to redesign the care and the payment models. Our goal is to apply what we are already doing in the private sector to the Medicaid program. While your hospitals do support the goals of the General Assembly, we do not support movement to Medicaid management by commercial insurance companies. This method has been piloted before in North Carolina, and it resulted in failure. Just last month, the Health and Human Services Oversight Committee was informed that the behavioral health care managed care organizations, those that we already use in North Carolina, would, like other managed care companies in other states, need more money to make it through the fiscal year. Medicaid HMOs have consistently been shown not to save money in other states. MCOs also manage by denial. Their claims to quality care are disingenuous as they do not provide direct patient care. Their only success can be had from the care given by doctors in hospitals and other settings. Why have the middleman when those same providers that you already rely on can ensure both the quality and predictability? In addition, instead of siphoning off state dollars, we have a world-class health sector in North Carolina, and we believe that working with the Secretary and the DMA, we can provide you with the details and the plan to have the reform that you have long needed. We encourage you to go with a provider-led supported Medicaid management, and we look forward to working with you on the details and bringing you the budget certainty as we move through the transition. Thank you.
Excellent.
Thank you. Chip Baggett with the North Carolina Medical Society.
Mr. Chairman and members of the committee, my name is Chip Baggett, and I'm Director of Legislative Relations with the North Carolina Medical Society. Thank you for this opportunity to speak to you once again about Medicaid reform in North Carolina. We believe that a physician-led accountable care model is the best way to move forward. That's been our consistent position throughout this entire debate. Such a model, similar to that proposed by the governor as a product of the Medicaid Reform Advisory Group and later developed for your consideration by the Department of Health and Human Services, builds on the long history of success that we have here in North Carolina. That success has its foundation in the primary care medical home relied upon by nearly every Medicaid patient currently in North Carolina. That physician network through Community Care of North Carolina has shown us that we can control cost through coordinated care and focusing on patients' needs. Accountable care organizations are the natural outgrowth, in our opinion, of what we have done already with primary care medical home. We believe that this is the only way that we can achieve long-term predictability within your budget while maintaining the integrity of the physician-patient relationship. By building on this joint success, doctors are able to focus on their patients, measure themselves against other physicians, and improve quality care outcomes through coordination. This leads to lower cost, not just through avoidance, but because this coordination enables Medicaid patients to accept personal responsibility as part of the accountability team working together towards better health for the patients. We all know what can happen when we focus too much on cost containment, and that's why we have focused on bringing you this solution that focuses first on the patients, access to care, improving quality, and saving money as a byproduct. We continue to work closely with the Department of Health and Human Services to build and maintain the infrastructure necessary for physician-led reforms to be successful in North Carolina. We agree with the department's proposed solution to Medicare reform because it's pragmatic, it builds on what we do best now, and is centered on assuring long-term, patient-centered access to health care without interruption. Moving to a value-driven system is not only inevitable, but is also the right solution for everyone involved. We look forward to continuing to work with you on developing the details of this solution, and happy to answer any questions at any time. Thank you very much.
Thank you, Mr. Baggett. Mary Bethel from AARP NC.
Good morning. Chairman Burr, Chairman Heiss, and committee members, I'm Mary Bethel with AARP North Carolina, and I'm pleased to offer this comments today on behalf of AARP. AARP is a nonprofit, nonpartisan organization with a membership of 1.1 million members in North Carolina that helps people 50 plus have independence, choice, and controls in ways that are beneficial to them and to society as a whole. Now, in addressing Medicaid reform, AARP North Carolina believes that we need to build on the things that are working in our state, and we need to allow adequate time to implement a capitated plan. Rather than offer comments on what the organizational structure for Medicaid should be, as a consumer advocacy organization, our comments will focus on principles which we trust will be front and center as Medicaid reform is implemented in North Carolina. And there are 7 things I want to discuss. The first principle, consumer engagement is critical. Medicaid is more likely to meet consumer needs if consumers and advocates are involved at all levels in planning and implementation, and AARP and I'm sure many other advocacy organizations today that have spoken offer assistance in this regard. Number 2, better health is the bottom line. Meaningful reform must address the central role that poor health outcomes play in healthcare costs. ensuring access to and utilization of preventive and primary care will reduce costs in the long run. 3, successful Medicaid reform treats the whole person, as we've heard many times. It's imperative to offer comprehensive services to improve health outcomes. This includes ensuring that aged, blind, and disabled adults continue to have access to optional services that are now part of our Medicaid benefit package. If services such as physical therapy and dental care are not offered on the front end, there's often a bigger cost on the back end due to increased admissions to acute care facilities and long-term care facilities. 4, special needs require special accommodations. Care that is well suited to the average person may not be adequate for persons with complex health needs, and we need to be able to offer a full range of appropriate services. We need to look at spending home and community-based services that have improved outcomes. Number 6 is Medicaid reform requires a robust provider network. It is imperative that patients have a choice of providers and do not have to wait long or to travel long distance for necessary care. And 7, we need to have means to ensure quality and accountability must be in place. Now, a few of the recommendations that we have is that quality and accountability standards need to be spelled out in contract arrangements. The management information system for the reform system needs to capture the information that's needed to effectively manage the system. And we need to create an independent ombudsman to maintain consumer hotline and other means for ensuring consumer protections are in place. And last but not least, we need to ensure that payment rates need to meet and are adequate to provide comprehensive care, and providers are reimbursed effectively. So thank you again for this opportunity.
Thank you, ma'am. That reaches the end of what we have on the public sign-up sheet. Did the chairs, did we miss anyone that had signed up that we didn't get to? All right. No, thank you. At this time, we're going to move into some committee discussion, if there is any. At the next meeting that will be held, I think the second week of November, we'll be reviewing and voting on some recommendations to take back to the full LOC, and the chairs welcome any suggestions, ideas, proposals that the committee members would like incorporated into a committee report that we'll bring back and send back to the full committee. So if you have suggestions, we'll certainly take them at this time, or take them as we move forward, preparing to move into that next meeting. So if there's any suggestions there, please get those to the chairs. Senator McKissick.
I was wondering if we will, as a committee, have an opportunity to hear from Madam Secretary and her staff about the information that we've received during the past several meetings, and particularly the meeting where we brought in all the directors, from Virginia, from Florida, Ohio, to try to see what their take may be. I don't know if there were questions that were in their mind or information they might want to share with us based upon information that we received. But I think it would be perhaps insightful to at least hear their ideas and perspectives as we move forward and consider what options are open here in North Carolina in a more formal way, perhaps. And I don't know if they're prepared to do that today, but it would certainly be helpful to me as a member of this committee to at least understand their thoughts, because I'm sure there may be aspects where we heard that they might embrace. There may be other aspects they might consider to be questionable, but I think it would be great to see if there are questions that they think we should be considering separate and apart from those that may occur to us as members.
And we have tried to make sure that the Secretary and the Director of DMA had an opportunity to present, and certainly to respond to those things. If they'd like to at a future meeting, we can certainly discuss that, or if Madam Secretary or Dr. Cummings, if you have any thoughts at this time, certainly welcome to state those.
Mr. Chairman, Senator, thank you. We are not prepared today for that, but I would
respectfully request for the opportunity to do that. We would like to summarize what the previous Medicaid directors had shared with us and in the public forum, if perhaps we can be allotted that time at our next meeting. Thank you, Senator.
Thank you, Madam Secretary.
Senator Hartzell.
Thank you, Mr. Chairman. I see Dr. Morrow has gone, but I have some vague recollection that the reimbursement rate for services provided by local health departments, the reimbursement rate to Medicaid, is less than it is for other similar kinds of providers. And I would like, if someone could confirm that one way or another. I'm trying to figure out why that is, if in fact that is the case.
Thank you, Senator. I'm Lynette Tolson, the Executive Director of the Local Health Directors Association. Yes, that is true. You will remember that there is cost settlement at the end of the year that local health departments do also receive. However, that's not the full dollar reimbursable. Also, we are worried and concerned that cost settlement will be ending very soon because the feds have told us to be on the lookout for that. So it's a very good question. I don't have an answer for that. That was done before my time, but we would love to talk further about that. Thank you.
Just follow up a comment, Mr. Chair. It seems to me that it would be useful for us to look at this. This is an institutional differential that seems to have occurred over time, probably just generated, I'm not sure why or what. But under any circumstances, it seems to me that we should be, in any program that we have, that we should be reimbursing like providers, like amounts, in some rational way. That's just a comment, and we could take a look at that a little more. I appreciate it.
Thank you, Senator Hartzell. Any additional comments? Chairman Heiss.
Thank you, Mr. Chairman. It's kind of interesting comments that have come in, and from what we've heard today, we've heard from a lot of individuals who look to be major players, from our hospitals, from our physicians, from our LME MCOs, as well as from private insurance companies that want to be a part of that. Each one kind of in their own way want to see what system is, from their point of view, would be best for the state and best for their industry that's kind of coming forward. I just don't feel that as a legislature that's a decision that we need to be making. That we don't need to choose which one of those to prioritize in the state and place out there. And that's why I have pushed from the beginning to open up the marketplace for Medicaid coverage in this state to all providers that are out there and allow them to compete for coverage in this state. Now, while we've chosen to make priorities for existing industries and others, to step in and say we're going to exclude certain providers because we have some mythical manner of how they spend their funds or what they spend on administration or other things is not the proper role of the state. And I think the argument could be made about any of those four major providers, true or not, with coming in with how they spend those or move them. And just to comment real quickly on DMA reforms in the department. DMA is something I'm supporting right now, is being reformed right now to function better today in operations. But when we look at both what the House and the Senate has proposed, in the future, whether that's 4 years, 2 years, we haven't agreed on a timeline, the Medicaid system will look very different in North Carolina than it does today. A full risk, capitated, and integrated plans. The skills and services needed on the state level to manage that is significantly different than what is needed under a fee-for-service system. We need fewer coders. We need fewer processors. We need to be able to actively at that point look at the care being delivered, to monitor health outcomes, to make sure that our patients are receiving what we are paying for in this state. That is not the function or the capabilities of the department at this point, and that's not what the new reorganization is achieving. I believe strongly that the only way to get there, under our current personnel systems and others, is to create a separate department. And moving forward, that if we're going to function as an overseer of insurance in this state, that we should be governed in the same manner that we see successful insurance companies governed in this state. That we need individuals who understand the billing cycles and the management and others that can come from the private sector to be able to oversee and focus on the budget predictability of the system as well as outcomes. I've talked to a lot of legislators for a long time who come here with a lot of priorities. But when we sit down to the budget process, there is only one priority, at least in 4 years, and that's been Medicaid. It is an entitlement program. We don't get to set how much we spend on Medicaid. We get to guess how much it's going to be at the first of the year, appropriate those funds, and hope that we got close. That's not true of education. That's not true of transportation. That's not true of commerce. Whatever amount we say we're going to spend, we're relatively assured that's the amount we're going to spend. But if we don't get control of this, there are no other priorities in the state that can move forward. We've been off on our forecast. I understand that. But we have put tremendous funds into Medicaid every year. If Medicaid continues to grow at the 6.5% or 7% that's forecasted annually, you're beginning to talk of adding $1 billion in spending a year to the process in Medicaid. Easily coming $350, $400 million of state growth a year. That exceeds any projection we have of what the revenues will grow in this state. Medicaid will continue to move forward. That's why we have to focus on these reforms, both on the payment side, how it's leaving, and on the department side. And I thank you for the comments.
Thank you, Chairman Heiss. Representative Avila.
Thank you, Mr. Chairman. I think one of the things that we're going to have to address before we address the model or the shape or the structure is outcome. No cost savings will take place unless we are giving adequate service for a good outcome. And currently, that set of parameters is in a state of development. And I feel like I don't hear enough focus on how we are developing what it is we want to accomplish, not just in cost savings, but in the health of the people that we're serving. And I would like to see a significant part of what we do in Medicaid reform focused on exactly that particular issue, regardless of whether it's an ACO or an MCO. I don't care. What I want are citizens who have the accessibility and a quality outcome at a cost, of course, that the state can afford. And in terms of the organizational structure, I have seen ridiculous organizational structures made to work because you've got good people in them. By the same token, I have seen perfect organizational structures on paper fail miserably because you don't have people that know how to administer. So in terms of where we go, our focus should be on a couple of things, and I see the Secretary in the direction that the department's going now, focusing on one that I feel is important, and that is the management skills that we put in place to accomplish what we want. And I feel like if we focus on the outcome, I believe it was Mr. Baggett that mentioned that money was the last thing after accessibility and quality. You'll get your savings when you figure out how to give people the best service that keeps them in facilities of lower cost. And it's just a natural byproduct of doing the right thing in terms of what your citizens need. Thank you, Mr. Chairman.
Representative Dollar.
Thank you, Mr. Chairman. Just a couple of observations, and I'll go back to a time when I was in an HMO, an MCO. I was actually a patient when the state health plan decided to try HMOs in this state. It was a much healthier population than what you see, a less diverse population than what you see with respect to the Medicaid program. That HMO system, there were several insurance companies engaged in that. They all, in a fairly relatively short period of time, went away. It failed. That experiment failed in this state. We also, there was a smaller test down in Charlotte back in the 90s that failed as well. But I particularly remember the state health plan failure in its effort to go into basically what was commercial managed care. It did not work. And we've also seen in other states, for example, in Kentucky, there were problems with a provider up there, an insurance company, not a provider, but the insurance company, because insurance companies are not providers. The providers in this state are some of the folks who have spoken today and that have been speaking for some time, saying they are willing to take on capitation. They're willing to take on full risk. The insurance companies or managed care companies, one and the same, are not providers. They do cost money. If you look at the cost, the total claims north of $10 billion, just using the rough numbers, the commercial managed companies would be taking at least $1 billion, $1.2 billion out of all that to run their operations and to provide their profit margin, and that would obviously have to go out of state. And we're not going to provide that money. The state's not going to. It's going to come out of services. It's going to come out of rates. It's going to come out of what is being provided. It seems to me that if the goal is predictability, if the goal is stability, if the goal is truly patient quality and patient outcomes, then what we need to do is we need to look for those innovations that have already been discussed and brought forward in the ACO model. We need to look to our providers and say, okay, we're going to put you to the test. We're going to let you are going to do the capitation. You are going to provide to us the budget stability that we're looking for, given that it is an entitlement program, as has been mentioned, and so, there are challenges with that. Our providers can do this, and we can work with them, and the department can work with them, and they can change the incentives in the system, because what we really need to control cost, and this is healthcare costs beyond Medicaid, are quality over quantity of service. Value of the service as opposed to being paid for volume of procedures. And our providers are ready to do that. Our doctors, our hospitals, our other providers are ready to do that because those innovations are already underway in the marketplace. I've noticed even in the last 2 months, we've had a number of strategic partnerships that have, in this market that I've been watching, but also in markets around the healthcare market around the state. We've seen some very innovative collaborations that are coming together. Thankfully, healthcare is not waiting on us. They have other payers, and they are moving forward with ACO and ACO-like developments. They are moving toward very interesting and innovative strategic partnerships in an effort to go where everybody, I think, agrees, and that is an ability to change how the healthcare system, how we pay and how we focus on treatment. I believe that this General Assembly, and I hope this General Assembly,
will build upon the innovation in the private sector that is there. Let's encourage that. Let's go for that. Let's not go for an older solution that has been very problematic in North Carolina in the past and has not proven to be terribly successful. We've got a tremendous opportunity to build in North Carolina, and let's hope we take advantage of it.
Representative Lambeth.
Thank you, Mr. Chairman. Actually, I think these have been very, very helpful sessions for us to frame and decide where we want to go when we get back into full session. And we've heard some really good comments, and I think we've learned some things from things we've heard. And actually, I think there's some very good comments around some similar themes that we've heard. For example, everybody talked about quality. I think we all agree that we want a quality product. We can do better in North Carolina to have a quality product. They've talked about whole person care, the role that CCNC plays in that, the MCOs and LMEs. So choice and access, talking about metrics and accountability, and then realigning the incentives. So I think we actually have many things we can probably agree on that we want to accomplish. And I think we might be making this a lot more complicated than we need to make. We need to decide on the principles and then let the department work out the details. And I think we actually can do that. I think a provider-led organization makes a lot of sense. I think we need to give them an opportunity to prove us wrong. I also heard when we talked about the reorganization that's a massive undertaking in itself. And I worry a little bit about taking on too much. We need to reform Medicaid, and if we need to reform the organization, can we actually do both of those at the same time? And I do have concerns about which one of those we want as the highest priority, and then taking on the second one if we in fact want to pursue an organizational change. But again, I think this has been very helpful, and I appreciate the chairman leading us in this direction and helping us gain better insight and information in this process.
Senator McKissick.
And my thoughts are somewhat similar to what Representative Lambert just expressed. I mean, we really are looking at two separate things, in my opinion. We're looking at an institutional structure that best organizes an agency, whether that's within HHS or whether it's some semi-autonomous or completely independent entity for management and operations. But then you're secondarily looking at the structure for providing those services, and they're separate, distinct, and you could potentially have a different structure and have a program that's similar to what the Secretary has recommended. So, I mean, but I think we need to keep those things separate and independent in our mind as we move forward. It was interesting to me during our last meeting when we heard the director from Virginia, and I said, well, look, if you can wipe the slate clean, do a new system today, not go to the direction that you've gone in the past, notwithstanding what you have done, what it would look like. And I was quite surprised to hear her say it would look like North Carolina's. So I mean, I think we need to not throw out the baby with the bathwater, so to speak. We need to really look at what we have good that's working intrinsically today and enhance its performance. My mind remains open in terms of what we need to do. I'm not sitting here saying that I know all of those solutions, but I do believe that we've gotten some very good information in over the last several meetings, and I think that working collaboratively, and I hope we can have some conversations kind of offline, not just here between some of us, whether it's in a conference call or whether it's in our respective offices, to really what I call churn through the ideas and see what makes sense, because that's really what we want to be able to recommend to our colleagues, and I really hope that we can work together in doing so. Thank you.
Madam Secretary, did you have additional comment?
Thank you very much, Mr. Chairman. Yes. Mr. Chairman, committee members, Over the last 20 months, the Department of Health and Human Services, along with the Division of Medical Assistance, has spent thousands of hours at this point working with multiple stakeholders in our state, from our citizens to our providers to the patients to the representatives of the organizations that have spoken before me. We have focused on creating a value-based, predictable, accountable, provider-led, and North Carolina-specific reform model that focuses on whole person care. We have submitted our plan in March, again, in March of this year. And we continue to strongly believe that the ACO model is a realistic, achievable, responsible plan for North Carolina. We respectfully ask to be allowed to continue to align the healthcare industry to meet our mutual goals and the goals of the citizens of our state. Thank you.
Thank you, Madam Secretary. Any additional comments from committee members? All right. If not, as I said, in between now and the next meeting, certainly any feedback, suggestions you have as we work towards the committee report, we welcome those, and we stand adjourned at this time.